that that's a massive travel day for you, but how very important this is needs to be stated loudly. This will be one of the final in-person work days for the fourth trimester initiative, and we have a jam-packed and wonderful celebration planned for you all that we really want to knock out the rest of the FTI projects with you all in person and potentially send you home to check the last of those boxes. So make plans to get there 9 a.m. to 1 o'clock on April 23rd. Carrie's been working hard also with me on the agenda. And while you won't see it there, that will come to you soon. We'll also have a list of things that we want you to bring with you and give you those further details after you register. You see that Tiffany has included the link there. We'll send this out in an email to follow as well, but it is, quote, mandatory. We want everybody represented there, every hospital and every champion. So make plans to get there for sure. Next slide. So a few reminders about, again, for all hospitals that are involved in the fourth trimester initiative. And if there are those on the call that aren't, we still are so happy that you're learning along with us. The things that are evident as we get into this last year of the fourth trimester are the pieces that are dangling. And I would tell you that in medicine in general, we know that we start a process with a patient, we complete the process, and then we typically do, a post-assessment evaluation. Well, the same is happening with fourth trimester. If you look at that black box that's right in front of you, those are the things that are included in the PowerPoint, which talks to all of those pieces. Where are you as a hospital on that part of the initiative? Where could you look to resources next, or what's the treatment, so to speak? And then how do you know that you've completed it? If you did not receive this final planning PowerPoint that has all of those pieces listed in that black box, the picture to the left is an example of one of those goals that's pulled out and gives explanation about what to do next. Please let me know as soon as possible, because this is the last piece of making sure that everybody has completed this initiative and gives you some ideas of how to complete. Next step, or next slide, please. As a reminder that we, as many times as I can bring this to everybody's attention and put this in front of as many people in Kansas, quite frankly, from at the bedside to those that make protocols, those that make laws, those that see each other at church, those that know each other well in the doula community. This model of care is the answer to how we help our postpartum patients. This is the final right? The final model. This is what we are all aiming to do. And what I'm hearing from some hospitals that are working through is they don't understand how it all connects. Because quite frankly, what we've done is throw a lot of changes and protocols at you, but to see the entire model in front of you is hard. And I get that. So if you ever have a question about how all these pieces fit together and how do they really improve outcomes, this is the visual I want you to always pull out. And it talks about birthing facility, the moment of discharge, and how that will connect the patient to the next person in line. We call that a warm handoff. But if we focus on the left-hand side at each of your facilities and we make connections to the outpatient follow-up, we will dramatically improve maternal outcomes quickly. So again, this is the new postpartum model, the big view that I want you all to keep in mind. Next slide. What is happening in March, April, and May is that we are focused in on the two benchmarks for the fourth trimester initiative, especially for Kansas, the patient debriefs after an adverse outcome and birth equity training, which quite frankly are teamed up together. If you pay attention to the training, you'll know that the most important thing that we need to do better is to listen and to include and to welcome in. And so again, as a reminder, as we touch base for a few more minutes here on what's happening with the fourth trimester initiative, but then transition over to our guest speakers today, the pieces that we're asking each hospital to do are to train your staff in birth equity. All staff should be trained in birth equity through Mama's Voices, through Kansas Birth Equity Network. Perhaps your own systems have birth equity training requirements. But to also remember that the key ingredient to birth equity is the patient, and involving them in briefs and debriefs prior to, during, and after an adverse outcome is a benchmark within fourth trimester for a reason. And we ask for you to make sure that that's part of your fourth trimester plan as we complete this initiative. Next slide. The next two trainings are in front of you. We've completed the March 19th training. And for those of you that joined us, you know how powerful those messages were from the patient, the father, the national representative who talked to us about the profound ways that we can improve the way that we listen to patients. We're going to continue. That's a repeat at the April 16th and May 1st. They will be live again. It's not that we recorded and we'll play it back for you. Those will be live performances, so to speak, at those two dates. But please make sure that your staff knows about those. Again, we encourage 100% attendance from all sites. And we're looking forward to those follow-up messages about birth equity and the patient debriefs moment. Next slide. So what happens next, right? You at your site or across Kansas, you receive the training on birth equity, you hear the message of why the patient needs to be the center stone of that conversation, but what do we do next? And I want to make sure that everybody knows training isn't the end goal. The end goal is the protocol or the change in behavior so that the outcome that improves. Where we are right now is the first piece of that, the staff and provider education. Again, that's through Kansas Birth Equity Network training. For those of you, the majority of you that have received that, I know some of our hospitals are finishing their portion of that, and then the next cohort will go in April. But the other part, of course, is the Mama's Voices training we just talked about, those 3 repeat dates that you can receive. That's where we are right now. What we're going to talk about and encourage next are extremely important, and they're called the action items. 1, self-evaluation. What does the person who's receiving the training, who's a participant at the bedside or in triage or in the ED, what is their evaluation of their take on the problem here? And the next step of that would be, of course, how do we hear and listen to the patient? And the follow-up to that is, how do we brief and debrief patients? And I put turbulence there because if you've heard the Mama's Voices training from just a week or so ago, you know what turbulence meant. How do we, through turbulence, talk, brief, and debrief in a turbulent time? I thought that was a perfect way for her to describe that. We evaluate, we ask ourselves how to, and how do we, and then we provide action. How do we take what we've heard and make it into an actionable step? How do we teach each other hard communication? How do we hold each other responsible for a hard moment? And then what do we do now? So we will follow those things up. It's part of our plan when we're in person next month. But I need you all to know, especially the champions, these are the pieces that come after the training. Next slide, please. I'm going to push past this one. This is the QHI question of keeping track of who's trained. We're doing that for you. All right. So how do we, or what are some best practice models that we can then make an action plan? So every hospital, every outpatient clinic, every triage unit, every ED needs to figure out how to improve the listening as part of birth equity. And certainly the story has to be a protocol change. It really does. We all need to have standardized, improved protocols. I grabbed Kim Dick and Dr. Bry from Stormont Vail, Topeka, because they're the only ones in the state working with the March of Dimes on a profoundly wonderful new protocol and new program that they're going to explain to you called TeamBirth. And this really is across the nation now a best practice model for several items, but especially for birth equity. Kim and Dr. Bry, introduce yourselves if you would, and take over for me.
Absolutely. Good afternoon, everyone. I'm Kim Dick.
I'm Dr. Bry.
We're excited to share with you how here at Stormont we have answered the call and created an action to address what we learned about last week with the Mama's Voices training. We know how important birth equity is and patient involvement. So we'll share our example of a best practice model to put the patient at the center of their care. Next slide, please. Quick little background. I'm currently the maternal child perinatal quality program manager. I've worked at Stormont Vail in the labor and delivery unit for 19 years. In the past 5 years, I have held a position with a focus on quality.
I have actually been very involved with the medical staff mostly. within Stormont Vale, but also am involved in KPQC and KBIN and the March of Dimes program we're going to talk about, as well as the fetal and infant mortality review in Shawnee County. Recently, the chief of staff here at the hospital, which I ended in October, so I've had a little bit more time to rest, luckily.
Next slide, please. Like Tara mentioned, Stormont Vale was fortunate enough to be selected by the March of Dimes to enter into their maternal health care collaborative in early 2023. This collaboration focused on three main elements: implicit bias training for nurses and providers, implementation of TeamBirth, and then a data submission piece. Today, we're going to focus on the implementation of TeamBirth, which was created by Ariadne Labs to enhance the safety and dignity in childbirth by providing a process for effective communication between patients and their care teams. Full disclosure, I'm using the slides from the maternal health care project that they have given to us to use for any collaborations. Next slide, please. So what is TeamBirth? How does it help? And why do we choose to implement it? We'll start with just the background and general overview. Next slide, please. Unfortunately, these statistics are no surprise, but it's also the reason that we are here and we are trying to answer the call to do better for the women in our country, state, and our community. We know that the United States is the only developed country with M&M rates increasing. Women are 50% more likely to die in childbirth than their mothers. We know that Black women are 3 to 4 times more likely to suffer mortality. And we know that 2/3 of pregnancy-related deaths may be preventable. We asked ourselves, what can we do to address these issues? And when we found out that 80 to 90% of the complications during and after pregnancy are due to a failure of communication and teamwork, we knew that we needed to start there to address our issues. Next slide, please. So that's where TeamBirth came in. The purpose of TeamBirth is to formalize really the process of involving the patient and their care team in discussions and decision-making. It's to address that statistic that 80 to 90% of the complications are due to that failure of communication and teamwork. The goal really is to empower each team member to participate and contribute to the shared planning for their care. You can see here that for patients, TeamBirth's main focus is to invite them into the conversation and make it easy for them to participate in the process. And then for clinicians, the main focus is to ensure conversations about the patient include the patient and helps keep everybody on the same page.
The team here is everybody that's in the room, everybody that's going to be part of the patient care. So that includes whether it be family members, a doula, a photographer, everything, and everybody will be involved in any of the changes that we're going to be talking about. And so we wanted to make sure everybody was included, even if the patient doesn't make the decisions of their team members. They're going to be making the decisions for themselves. So, yep.
Exactly. Kind of a fun little example of this is, have you ever taken care of a patient and you're at the desk, so the provider comes up to you and says like, hey, let's get Pitocin started. So you go in the room and you're like, hey, we're going to get Pitocin going, get your induction underway. And the patient's like, I don't want Pitocin. So you're like, oh, so you run out to the desk as fast as you can. Thank goodness the provider's still there. You catch them and they say, okay, how about I break her water then? You're like, oh, let me go ask. So then you go back to the room and you say, okay, are you okay with them breaking your water? And the patient's like, well, only if I can get my epidural first. So you go back to the provider and you say, she's willing to have her water broke, but she wants her epidural first. So really this is to just prevent that. We all know that that's basically an example of a disconnect between the patient and the provider. There's opportunity for misunderstandings, and implementing our TeamBirth principles will prevent that situation and any of the possible poor outcomes that could arise from a situation where misunderstandings are created. Next slide, please. TeamBirth has 2 main principles and 4 core behaviors needed to be effective. The principle of teamwork is really to promote and engage the entire team, to create a safe space for discussions and decision-making, and to really focus on the patient's personal feelings, questions, needs, and desires. The other principle of simplicity is really, it's just that. It's making the process a simple but effective way to communicate not about the patient, but with the patient, like the example we just talked about. As far as the 4 core behaviors, you can see it's more of a checklist to have that every patient communication should focus on and try to include. We want to make sure that each member of the team feels comfortable and is invited to the conversation. Like Dr. Bride just said, it's not just the patient, it's their support, it's their mom, it's the photographer, whoever's there. We all want to get each other on the same page and make sure that everybody is included. When including them, we want to make sure that we're encouraging them to communicate what their preferences are. This will help them participate when we discuss the plan for the patient and the baby and the labor. Each communication should really end with a clear expectation for when the next communication check-in will be. And then you can see in the 4th core behavior, the term huddle. Huddle is actually what TeamBirth refers to these little communications are. So anytime we get together and we talk, we call it a huddle. So from here on out, you'll hear it called huddles. I just kind of wanted to explain what huddles were really before we switched our language over. Next slide, please. TeamBirth has used the concept and process to really create what they feel like should be the industry standards process to help address these communication issues that lead to the poor outcomes that we've been seeing with our moms. On the left, the structured team huddles are what we've been talking about. Again, the team member meetings with the patients. And then just below that, it mentions tools that TeamBirth uses to help guide and record those huddles. So basically it's a planning or a whiteboard to be able to write the key points of the huddle on to kind of keep track of those thoughts and preferences. You will see some examples in an upcoming slide that we have. That middle area just kind of highlights the data collection piece I spoke to earlier. Our collaboration with the March of Dimes and TeamBirth includes ways to like measure our success, employee feelings towards personal and unit implicit bias, as well as like patient experience, ratings and comments. And then to the far right, it's why we do this. You know, we want better childbirth outcomes, definitely improved patient experiences and quality of care. Next slide, please. Okay, so here's what a TeamBirth huddle should look like. It has the patient and her support team, as well as the provider and the nurse engaged in a conversation. And then the team is utilizing that planning or whiteboard to ensure that everyone's on the same page. I will mention an alternative to the in-person huddles, like the one that's shown, are huddles done over the phone. It's perfectly acceptable and sometimes necessary in order to get provider involvement, especially if they're not on campus, to do a huddle with the provider on a speakerphone. So really, as long as the huddle is completed with the appropriate team members and allows the patient to have a voice, then the objective is being met. Next slide, please. Okay, so this slide is basically the down and dirty of who, what, when, and why we perform our huddles. We've talked quite a bit about like the who, the what, and the why. I just want to make sure we make the when clear also. So when is definitely on admission with any change in plan, and really whenever anyone on the team wants to. So whether it be the provider, the nursing staff, the patient, or even their support person. These might be an hour apart. They might be several hours apart. It's just going to depend on what's going on with the patient. I don't really want there to be a lot of focus or get too caught up on like how many huddles you need to have or when the perfect time is to have it. Because honestly, it's quality over quantity, and the providers will learn that really quick. So if on admission, you have a good, thorough discussion of what's going to happen. So for example, patient getting admitted overnight for like a cervical ripening. You might be able to have that discussion when they first arrive, explain the plan for the entire night, and you might not need another huddle until the next morning when things get, the plan of care gets updated. But on the flip side of that, if you don't really do that initial huddle, then you might find yourself back in that situation earlier of going back and forth between the provider and the patient, or have questions, uncertainty, and not really know, the patient may not know what the plan is. So that's really, I guess, where provider buy-in is really important. Next slide, please. Here's an example of the whiteboard planning board that TeamBirth shares. It has all the elements that should be addressed during each huddle. And like I said, this is just the example they give, and then each hospital is able to adapt and personalize their boards. They just ensure that all the components are included.
We had our own boards initially that had a lot of a lot of the components on it, but didn't quite have everything that the TeamBirth or the March of Dimes would like for us to have, and so we've really tried it both ways, and yeah, the more information the better for sure.
Yep. Next slide, please. All right, here we're going to really highlight the features and outcomes of our TeamBirth implementation. We're wanting to elevate the patient's experience and input in their care. We definitely want to mitigate our staff's implicit bias, and we definitely want to improve the culture of our unit. So these together show how they can help reduce unnecessary C-sections and minimize preventable morbidities. Next slide, please. So I know research isn't the most exciting talking point for several of you guys, so I only included one slide about it, but I just wanted to highlight some of the data points that TeamBirth implementation has been able to improve. As you can see, the majority of patients felt like their desired role in their birthing experience, and they reported clear communication with providers, which allowed them the ability to share their care preferences with them. And most importantly, most of them felt like their preferences made a difference in their care. So again, we know this is important. We know it's impacting the patients. As far as the clinicians, the majority felt that TeamBirth improved the care for their patients and recommended it to other units. That last data point, 84% of clinicians said they used TeamBirth to engage the patient in the decision for the plan of the C-section and non-urgent situations. I know we all think we include the patient every time in this decision, but this is on a different level. It's that deeper understanding, that deeper engagement, that deeper communication. So that way, during a huddle, a patient knows that they really are the decision maker when safety and time allow. Next slide, please. Okay, so TeamBirth at Stormont-Vail specifically, we kicked it off the 1st of November. The picture on the right is during one of our 2 mandatory all-employee trainings that took place in October. And as you can see, we had a fun kickoff. We got t-shirts just to kind of celebrate the dedication to the new initiative and to bring awareness to our clients and our patients. We, of course, knew what TeamBirth was and what we were dedicated to doing, but they had no idea. So this was kind of a talking point and a walking advertisement, basically saying that we are committed to our patients and this opportunity to make them and their experience the best they can be. Thank you. Like Dr. Bright mentioned, trial and error, we realized that we needed a supplemental board. And so on the back of it, one of our awesome labor and delivery nurses was able to create this labor menu. This is something that our hospital did. And when we shared it with the March of Dimes leaders, they have shared it with the entire cohort to show them just the greatness that's come from this. So basically, I hope you can read it, but basically it allows every patient to be offered the same options during their labor. We felt this would be a great way for nurses and patients to discuss the options we have, and also to ensure that each patient gets offered any and all options. We all have our favorite things, and we may not offer some of our non-favorite things. So this is just kind of a way to standardize and ensure that everybody has all the options that are possible to make them have the experience that they want.
And everybody feels better, like when they really do feel like they're picking something. Like it's like you go to a restaurant and you order off the menu. It's the same thing. They really feel like they're getting what they want and given all the options that we have. So we're not picking and choosing, like she said.
Yeah. Next slide, please. And then one last thing we were able to implement and share with our cohorts was our Epic documentation integration. So we worked with our IT team to create a way that we can document the huddles and the elements that we are including in the huddles. We can document when it's completed, why it's done, who was in attendance, and then any discussion or updates with the plan of care. We monitor this monthly. We break down the data. We're wanting to ensure everybody is getting the same opportunity to be included. We break it down by racial and ethnicities, just to make sure we aren't accidentally leaving anybody out, and then to just verify that we are practicing our implicit bias skills. And then lastly, again, here's a picture of one of our huddles on the postpartum unit with one of our midwives, Kristen. She's on here today. I saw her name earlier. you can't see the board in this picture, but you can see the patient, she's delivered, the nurse, the provider, and they're just kind of having a discussion and giving the patient time to ask questions, debrief on anything that's maybe happened during their stay, and just kind of have another touch point with their whole team.
So I know that sometimes the providers aren't as easily swayed to do new things. Always a talking point anyways. And I do and have learned recently that the patients will tell you, especially if there's a change of provider in between, that they'll be like, I definitely felt that you were, talking to me at every change, and they can really notice a difference, especially if there's ones that aren't doing that. And so communication with the providers and keeping them aware of what comments are made throughout this whole process is excellent too, because it really is about buy-in in these kind of situations when everybody has to make a few changes. I think it is better for everybody in the end, for sure. Any questions?
I'm going to jump. Dr. Bry, tell me the hardest part about on the provider side. I was going to ask you the question you already answered, but can you go a step further? Was it explaining how it went? I'm sure, Kim, on your end, there was the staff bedside training, but on the provider side, do you have to explain the minimum criteria, or how does that go on that end?
A lot of the times I let the patients lead, especially if it's not really my patient that I'm talking to. I'll let them lead and tell me what their providers have said, so that I can add on or tell what I usually do. But I really let the patients give me the information that they want, and then I kind of offer little put-ins. If this doesn't happen, then I would consider this. And for a lot of providers, this information, they already do this stuff. Like, a lot of providers really they already talk to their patients about all of these options and talk to them about what's going to happen here and expectations and stuff throughout their prenatal care, at the visit before they schedule something, or right when they get to the hospital. But if there's a different provider, I think that's probably the hardest part, because you don't know really what to expect with each of the people you share with. I think the debriefing we've always done too, but not all providers, just like the huddles, not all providers wanted to be involved in it. And having this huddle, and we kind of call the debrief a huddle now too, and having all those points where, okay, now I need to document this, and you're going to come in, and we have reasons to get them to be involved, and that's helped a lot too.
We've encouraged our nurses to help the providers by choosing my words wisely, by taking, say, the phone call ones, to just say, hey, Dr. Bry, this is Kim. I'm walking into Sarah's room today. We'll do our TeamBirth huddle. Or when you answer the phone, same thing. If they call you, if you've paged them and they've called you back, hey, Dr. Bry, we're in Sarah's room and you're on speakerphone. We're going to do our huddle real quick, and just kind of help their engagement by leading that participation effort.
Yeah. I think a lot of providers, actually get into the room, or, the nurse is getting the patient checked in, and the provider will come down and talk to the patient at that time. And that'll be the huddle. Mm-hmm. That happens a lot. Usually it's the in between, when the patient has questions or something, that we do an alternative. Hey, I'm going to call you. You're in the operating room, but we can just kind of talk through it real quick. And it doesn't take more than a couple minutes. So.
And one last thing, is our providers are really good about coming in on a mission. Like she said, coming in and checking in on them every few hours or things like that. It's more that part was being done. It's more a matter of focusing on the communication itself, instead of walking in and just saying, hey, how you doing? I'll be back in a little bit to break your water. They're saying, how are you feeling? Do you want us to break your water? Are you okay with that? It's more change as far as gauging the conversation than the actual conversation is
Yeah.
happening. Our providers were great and involved. It's a matter of getting the patients to feel comfortable
Yeah.
and invite them into their care. Like
Yes.
they want to be a part of it. They don't know they can be a part of it.
Yeah.
So we are setting that expectation that, you know,
It is about the quality of the information that you guys talk about. Yeah, that's for sure.
Other questions for these guys? I know if you would like further information, Kim or Dr. Bry, can you just send the link to Tiffany or I, and we'll include that in our send out for the listserv, the March of Dimes link. Okay, thank you. But other questions for these folks? I would tell you that TeamBirth is probably going to be the expectation moving forward. If I'm being honest, I think that this is probably where all hospitals and systems are going. It also, as you hear, it took a little bit of work, but quite frankly, we're doing some of it. We just need to push ourselves to the next part. And the patient is the center stone. Right. This isn't profound medicine, guys. This is really bringing it back to the bedside and listening in, despite a very active schedule for everybody involved. Right. But questions, jump in.
Tara, this is Kara. I just think this is so great. I put it in the comments, but shared decision making is one of the buzzwords everywhere, right? And I think I love the discussion as a provider role. As a provider, I thought I was always doing a good job and being patient-centered, but it's really fascinating how our language of I'm gonna break your water now versus an option is to break your water. What are your thoughts about that? Are you okay with it? Is totally different. So kudos to you guys. You're doing a great job. And it's definitely a team process to make this kind of culture change. So kudos.
All right, you guys, thank you so much for your TeamBirth presentation. And again, we will share that out to the listserv. For those of you that want more information, you're welcome to reach out to Carrie or I, and certainly directly to Kim and Dr. Bry as well. So the rest of our time together today is going to be specific about the first trimester benchmarks that are quote, left to attack, so to speak. If you are not a first trimester site, you're certainly welcome to stay on and hear what's happening and what we're recommending for the postpartum model across the state. But want to make sure you all knew that we're going to hit a couple of things pretty hard, and then I'm going to try to let everybody out a little bit early today. So the three pieces that I want to talk about, and again, it kind of ties into the conversation of a continuum of care versus segmented or provider-driven care, is the piece of the comprehensive postpartum visit template. So what happens after discharge from the birth facility? The community resource list. The patient needs what, and do we have it set up for her, or how do we make sure she gets that resource or that help that she needs based on your community's list? And then the all important, cannot state it enough, has to happen in Kansas, the standardized postpartum appointment made prior to discharge. If there was one thing beyond post-birth that I wish I could change, literally with the click of a button, it would be that every patient leaves the birth setting with their postpartum appointment already made. We know that that dramatically improves outcomes. So let's walk through these three things just for a few minutes. And then again, champions, hear us say that there is plenty of resource and content in that postpartum, that final planning PowerPoint that I sent out. But hopefully these conversations will help a little bit. So next slide, please. As a reminder to everybody about the report card, this somewhat busy slide is really just to remind our fourth trimester champions and OB providers that every hospital should have an updated report card of the fourth trimester projects. On the left-hand side, yellow is our goal. We want all yellow petals. That would mean that that part of the fourth trimester project is completed. If it's blue, that means that you're in process or in progress of achieving completion. And one means that you have not started. An explanation of every benchmark is on the right-hand side. And again, you will each be asked to bring your report card to the April in-person training or event. It's not training. It's a conversation that day, actually, guys, but asked to bring that with you. And we will go through and help you achieve from blue to green, or excuse me, from green to blue or from blue to yellow. Next slide. So when we talk about, again, one of those petals is this comprehensive postpartum visit template. This has been a little bit of a vague piece of the initiative, only because it ties in a very interesting way what the hospitals or the birth center's role is in terms of at discharge, what information needs to be passed along. The AIM National Bundle says that it is our responsibility at the birth setting site that upon discharge, a standardized discharge summary is included in every, or sent along, I should say, to every postpartum visit location. So in other words, before discharge or at the time of discharge, every patient will have a standardized discharge summary, and that will be sent to the primary OB seeing her in the postpartum setting. Outpatient clinic is the most common scenario. Could be an FQHC, could be a health department, whoever that person is, her discharge summary needs to be sent on. Furthermore, the bundle is clear that we need to help all outpatient clinics seeing postpartum patients make sure that they're doing the key items in what's called the comprehensive postpartum visit. ACOG has set those items out. They've made a specific checklist of what needs to be included in a comprehensive postpartum visit, to include looking at that standardized discharge summary that they received from the hospital. And this next slide will talk about that. So next slide, please. It is our goal then that every site shares out with all clinics and agencies that see postpartum patients in your region, or if you're a tertiary care center, anywhere where you will receive or send patients back to the comprehensive visit template. I put in this slide, and again, you all received this, an example of wording that I would encourage you to send along to those clinics. It could be on a letterhead. It could certainly be in an email. It could be in something attached so that the providers, the office management, the nursing staff knows what this is about. Again, really what you're saying is, as a part of the national initiative and the state project for Trimester, we want to make sure that you all receive a standardized discharge summary and that your postpartum visit matches up with ACOG's latest recommendations for that visit. That would be, and again, better stated in that paragraph you see there. Next slide. Again, I encourage you to look at this and to include this piece of this model as well, how it connects to the next part in line, right? So the facility discharge is on the left. You see that orange arrow pointing to providing the standardized discharge summary, making her appointment too. But then the next person in line, of course, is that outpatient clinic, and making sure that we submit all of those necessary documents. And again, connect her to that comprehensive visit made by her OB provider with those items included in that visit. Next slide. These are the items that should be included in the standardized discharge summary. Again, this is ACOG criteria, very specific. It's in the implementation details put out by AIM in 2021, but this is pulled out of the ACOG compendium statement. Those are the items. I'm not going to read them to you. Most of you will recognize those as a part of your discharge summary already, or perhaps the delivery summary with a few items added to it. But it's very specific criteria that should be included in what's sent on to the OB provider seeing her in the outpatient setting. Next slide. And then this is the template that we're asking you to share out. Again, I've sent this to you all via email, champions. If you did not receive it, nudge me and I'll send it again to you. Again, you'll see it in your PowerPoint as well that you got. But the comprehensive postpartum visit template is as follows. Again, outlined by ACOG. We didn't create this. This is a national standard of care now. These are the items that the postpartum visit should include. You're not telling them they have to. You're saying, as part of a national initiative, these are the pieces that are now being recommended to include at her visit in the outpatient postpartum setting. And those are the pieces that need to be done. Next slide. This is a different way to be specific. So the previous slide was the general terms. These are the pieces that, for example, you would see in a checklist, or you would see them in an EHR that drill down to the specific, for example, feeding method of that postpartum patient, plans for contraception, chronic disease management, right? The drill down of what needs to be asked or followed up on. Very helpful document. Again, shared out earlier. If you need it, I can send it again. Next slide. All right, we're going to keep moving here, guys. So that's the comprehensive postpartum template. We ask you to, every champion needs to share that out to all your outpatient clinics. That's a check mark item, very important piece. Now we're going to move into the community resource list. I will tell you all that when I see that most of you don't have this part done, I'm surprised. And when I talk to hospitals directly, I realize it actually is done. You just don't feel like it's complete. So next slide, please. The simplistic way for me to reassure you or to have you complete your list, which again should be part of every first trimester hospital and birth center, is that we ask you to create and maintain the following, which is specific for your community. We all know that rural sites are much different than urban sites in terms of the availability of all of these items. But I would also tell you, if it's not available in your community, that's okay. But who's the connection to, if she needs ... where do I find that for her? So simple stuff right there in the criteria to the left. Again, you do not have to have all of those items in order to make that check mark occur. Let me bring your attention to the behavioral health agencies. This is an example of why some people are telling me their community resource list is not complete, and I beg to differ. We know that our work with KCC allows for every provider, every agency, every hospital to be directly connected to behavioral health management or referral. So if you feel like that's part of what's not available in your community, I agree with you. Not everybody has behavioral health available in the postpartum setting. But if you know we're the next person in line to get her there, that's a check mark item. So take a look at that list. I bet you all have it. If you don't, reach out to Carrie and I, and we will help you find those folks in your community so that that community resource list can be complete, and you will have those agencies and those folks to help your patients prior to and after discharge home. Those are important connections. All of those folks that are listed there or programs are on that postpartum model that we talked about. Next slide. That would be what I just talked about. All of those folks listed there. Next slide. One of the things that I did for a couple of places, Shawnee County was just, in the last year, they were working hard to say, okay, I'm going to use that list in the postpartum model, what you just saw pictured, but we want to make sure we have everybody included. And there may be gaps in what we don't have that we want to find. And so what we did was called community resource mapping. This made it not just a list, but really an active document to say, hey, if we have a patient support network missing for this patient, who are the folks in Shawnee County that I can connect her with that can be that surround dynamic group of folks to help her? And we listed those pieces. Who are the behavioral health specialists? Where is WIC located, et cetera, et cetera. This was very helpful in many communities across Kansas. KDHE has teams of people to help you map this out and to get you connected to. If this is something you're interested in, we are happy to help and drill down further so that you know the specific agencies that meet all the marks. Next slide. Last thing we're going to talk about, I kind of already harped on this, but I'm going to do it one more time just to poke and prod a bit. Postpartum visit scheduling. I told you that it is vitally important. Why? It's vitally important because what's going on is that our patients are not coming to their postpartum visits. And guys, if we're talking about why, my suspect is there's a part of this because they don't feel like we want to see them, or we don't have time to see them after the baby's out, or that they feel like they're not going to be heard. Perhaps they had a rough birth or postpartum event and they don't want to face us again. Whatever the reason, to include transportation, insurance, I got tired, I'm depressed, whatever the reason. It should not be the reason that we didn't set them up for success. And we know nationwide that 60% is our attendance rate for postpartum visits in the United States. That's pathetic. That's not a passing grade. So Kansas has said that the postpartum visit scheduling should now occur prior to discharge home in all birth settings. Next slide. It is then our goal that every hospital prior to the end of this year has that benchmark accomplished. Okay. And furthermore, it counts. If you look at the note, primary OB provider appointment may be made for the patient at any of the following times. If they see them for a 2-week postpartum, if they see them for a blood pressure check, if they see them for breastfeeding, whatever the interval of time, whatever the need for the patient, it isn't just the 6-week mark. While that's an important time, we know that up to 12 weeks is counted within the comprehensive postpartum visit time frame. So if she's made an appointment for an OB provider appointment at 2 weeks or 48 hours or whatever that is, that counts. And we know that you've got her to the next step in line so that the OB provider has done an assessment and is available for help. Next slide. I like this day I was liking the arrows, wasn't I, everybody? So again, a reminder where this fits into the model. We have her set up for success at discharge. We've made that appointment. We have the standardized discharge summary. So the next person in line knows what's happened at her birth if they weren't part of her birth, even if they were a reminder. Then she's connected perhaps with navigator services or community health workers, but she's set up for success to attend the postpartum visit. She's connected to resources in the interim with what is needed and helped to connect, for example, breastfeeding with or housing, transportation needs. And the loop closure is that comprehensive visit with her OB. Next slide. And just a gentle reminder, if there's providers or office managers or billing folks that are saying, you know, this is all well and good, but we're not being paid for it. We're listening, we hear you, but good news is that that's improving quickly. And furthermore, ACOG says this is now the standard of care, very clearly outlined in volume 131 back in May of 2018. So it's time for Kansas to catch up. I put arrows there and you can read this when it gets sent out to you about why and how early and how often. This document is a great one to Oh, I was muted. I'm back. Okay. That was technology taking over. Next slide, please. And this is just a reminder of the same thing, you guys. Again, this is the ACOG criteria for when they need to be seen. You see that a blood pressure check with a high-risk patient should be within 3 to 10 days after discharge. We know that all contact with all women should happen within the first 3 weeks. Do not wait 6. We know that we want ongoing follow-up to happen along a continuum with all the folks that need to be involved. And then the comprehensive postpartum visit. So instead of one touch at 6 weeks, we now know that multiple touches by multiple helpful people, including the primary OB, are critical. Next slide. And that's it. We are going to close for the day. Again, lots of content, hopefully helpful on multiple avenues, and then bring questions, ideas, brainstorming options for our huddle when we'll see our champions on April 23rd. Again, make sure that you register as soon as possible. Tiffany will be sending that out as well as a gentle reminder. And we will dig deeper and get lots accomplished for Kansas. You're doing great things. We just want to make sure we continue to do so. I appreciate it. Oh, I think there was a question. There will not be a Zoom option for those that can't make it to Topeka. And then, Tiffany, did you see that question? I think it escaped me now.
The official visit is for the newborn. Does that count as a 2-week follow-up for mom? Or does she need to be registered and have an official appointment scheduled as well to be sufficient?
Yeah, good question. So if the newborn is seen by somebody that's also maternal OB related, then that would count double. But the maternal side has to be assessed and has to be identified. So she has to be registered as a patient for it to officially count. Though I will tell you that many places are doing breastfeeding clinic or newborn weight check or some version of that, but honestly, unofficially doing maternal evaluation, and we want you to get credit for that. We know what you're doing. You're doing that. You're doing the work. We're just not documenting it or for that information to be documented to go out to the primary OB provider. Any other questions? All right, you guys, we'll let you go a little bit early today. Look forward to seeing everybody in April. For those, I think it's on the next slide, Tiffany. The next Zoom. Yes, I did remember. May 28th. We'll see everybody back virtually on that day with lots of questions about social determinants of health and intimate partner violence training. Have a great day, everybody.